Good evening to everyone. Good morning, Dr. Yeshwant. I would like to thank Dr. Yeshwant for having accepted my invitation to conduct the webinar. On behalf of the Department of Oral Pathology, SRM Dental College, Chennai, I extend a warm welcome to all the faculty members and the postgraduate students from the specialty of oral pathology throughout the country. I'm sure that this webinar, a collection of unusual tumors and lesions of the jawbones and oral mucosa, would greatly heighten your knowledge in oral pathology. I now request Dr. Dinesh Kumar to introduce the guest speaker.
Good evening and a warm welcome to one and all present here today. It is indeed a great pleasure in having Dr. Rawal with us today to share his expertise in the field of oral pathology and enlighten us. Dr. Rawal is a professor of oral and maxillofacial pathology in the Department of Surgical Sciences at the Marquette University School of Dentistry. He is a fellow of the American Academy of Oral and Maxillofacial Pathology and a diplomat of the American Board of Oral and Maxillofacial Pathology. He is also the director and examiner of the American Board of Oral and Maxillofacial Pathology. He is a member of the Test Development and Construction Committee of the American Board of Pathology. He has held many leadership positions, including the chair of the Fellowship Examination Committee and the Virtual Microscopy Committee of the American Academy of Oral and Pathology. He was the past chair of the Oral and Maxillofacial Pathology section of ADEA. He is a reviewer for many journals and is on the editorial board of the prestigious journal Head and Neck Pathology of the American Society of Head and Neck Pathology. Dr. Rawal maintains busy scholarly activity with invited presentations, continuing education courses, and over 60 publications and abstracts to his credit. I welcome you, sir, to this gathering, and like everyone present this evening, I am also very eager to listen to you too. Thank you, sir, for your presence, and over to Dr. Rawal to enlighten us.
Thank you so much. Thank you. Let me get the screen up and going. And are you able to see the screen first? Please let me know about that.
Yes, sir. We are able to see it. Yeah.
Okay. Are you able to see a laser pointer moving on the screen as well?
Yes, sir. Perfect.
Okay, great. Thank you. Well, at the outset, let me express my gratitude and thanks to my good friends of so many years, Dr. Raj, for extending this invitation to me, and also to the higher administration of SRM. I have visited that school once before at Dr. Raj's invitation, and I know many of the faculty over there, including your dean, Dr. Ravi, and once again, a good evening to all of you. And thank you very much for this invitation and allowing me to share a whole list of, this is by no means comprehensive. I do have a lot more, but then, you know, we need a lot of time to share many more cases, but we'll try to get through as many interesting cases as we can in these 2 hours. And so at the outset, let me first outline a few objectives for people who are participating in this course. Once you have finished with this course, you'll be able to recognize clinical features of a select group of oral mucosal lesions, and you'll also be able to recognize the histopathological findings in a select group of mucosal, salivary, and bone lesions. And you'll also be able to recognize as to what immunohistochemical markers you may pull up to use in the diagnosis of some challenging tumors and lesions. And so I want to make it clear that this course discusses only diagnostic features of relevance of these conditions. So the intention here is to share some unusual cases. And so this course does not include any detailed management, although I will be glancing through some management criteria for some of these lesions and conditions. And of course, these are interesting cases. So everybody is going to be curious as to what the diagnosis is. As we course along the PowerPoint, you could have a notepad and a paper or pencil and, keep writing down the findings that you see on the screen and come up with your own diagnosis. And, you can give yourself a pat on the back if you, come with the right diagnosis. many of you are really brilliant. And of course, there's, nothing cryptic about these cases, nothing that is so challenging. They are straightforward cases, except, these are things that we don't see on a routine basis. And one has to bear some of these oral manifestations of some of these conditions in mind when we see some either radiographic, clinical, or histological features that are not common. Okay, so I'll be talking about soft tissue lesions first, then we move on to bone lesions, and then I'll wrap up with a handful of salivary gland lesions. And I know as oral pathologists, we like to focus a lot on histology. We like to see blue and red, slides. So yes, there will be a lot of clinical pictures. On bone cases, there'll be a lot of radiographs, and there'll be, of course, a lot of histopathology. I'm sure that everybody's interested in that. I guess so far as questions are concerned, you guys could, keep jotting down your questions. And from my conversation with some of your faculty who are arranging this seminar, I was to understand that, your questions will all be passed on to a single person who will probably ask the questions of me at the end of the seminar. So I'm not sure whichever works best for you, but it's a Saturday morning over here. It's bright and sunny, and my time is your time. So I'm not restricted so far.
Hello. I think there is an interruption from Yeshwant sir's side. Kindly hold on so that we can get this right.
Why am I having screens?
Sir, your screen sharing has stopped.
Yeah, so it keeps doing that. Okay, how about now?
Yeah, now perfect, sir. Yes, they're able to see.
Right, so it did that on its own, so I hope it doesn't keep happening, but at least I know what to look out for. So what you see over here is a photograph of the gingiva, and you can see on the left as well as on the right sides, some glancing shots of the buccal mucous membrane. And so, superficially, all these look like, clusters of ectopic sebaceous glands or fordyces granules. But then that would be too easy, wouldn't it? And you don't have such a prolific case of fordyces granules. This is not something I would put in this, talk. But so if you know the diagnosis, just put it down on that pad of paper with you, because I have a second case of a similar condition. And so, okay, now I'm having problems with forwarding my slides. Okay, here you go. All right, so this is again a similar case, a different patient though. 61-year-old male patient with crusty lips, edema of the lips, no pain, however, and pustules of the mucous membranes and fissures in the mucosa. He doesn't, however, have any significant medical history. I'm going to try to reduce this over here because this thing is blocking my. Okay, let me see how I can do this. Okay, that's okay. Fissures in the mucosa and no significant medical history, and so a biopsy was attempted. So here's the picture, and you can see this is focusing on the lower lip in particular. a lot of crust, but if you go beyond the crust, if you see on the vermilion where the pointer is, you can see there are, submucosal yellow papules. And so these are actually filled with pus-like material, so let's just call them pustules for the time being. And so this is inside, and you can see some of those pustules. You can see a cobblestoning. I know where you're going with the diagnosis. And so you can see cobblestoning of the gingiva here. You can see vertical, or rather, excuse me, horizontal fissuring in the vestibules over here. You can see there are some pustules on the lingual attached gingiva of the lower anteriors as well. And here's another shot, and you can see those linear fissures of the labial mucosa. And so here's the biopsy. And you can see the epithelium is quite acanthotic, but there's some eosinophilic plasma pooling. And this is, of course, a lip biopsy. So he's been chewing his lip. So this is secondary to trauma. You can see some inter and intracellular edema. And of greatest consequence is you can see these inflammatory cells going up into the epithelium. And so here's a close-up of one of those pulpated pustules. And so what you see over here is a microscopic finding of one of those pustules. There are, of course, despermating epithelial cells, but this is predominantly filled with a lot of neutrophils and with scattered eosinophils. And so this is a neutrophilic pustulosis. And again, in the superficial connective tissue, you can see a mixed inflammation, but there are prominent eosinophils, as you can see in the most superficial portions of the lamina propria abutting the basement membrane. So if you have given yourself a diagnosis of piostomatitis vegetans, you're right. Please give yourself a pat on the back. And so colonoscopy was suggested in this person, and the diagnosis following the colonoscopy came out as evolving ulcerative colitis. So the take-home message in these two cases is that in many patients with evolving GI conditions, the mouth findings may be first, and probably maybe the only findings. The patients may be otherwise asymptomatic. And so please be aware of these intraoral findings, everything from ragged fissures to cobblestoning to ulcerations to piostomatitis vegetans in patients with ulcerative colitis and Crohn's. So let's move on to the next case. We are still in the GI system. This is a very interesting case, a younger person. 35 male, several week history of non-healing linear ulcers, elevated and fissured ulceration of the mandibular right alveolar mucosa. He also suffers from abdominal cramping and runny stools. And so I know those pens are going really fast on those pad of paper. You already know the diagnosis. And the patient also suffers from inability to put on weight. And so here is a clinical picture that was sent to me by the oral surgeon. And you can see that linear fissure at the mucogingival junction almost. And here's another shot of the same lesion. You can see that linear fissure. It almost looks like a denture epulis, except that we are talking about a young person with a full complement of teeth and doesn't wear dentures. And so the surgeon had attempted a biopsy of this area. And so here's the histology. And so that's the fibrin area of the depth of the linear fissure, and deeper down in the connective tissue, you can see these conglomerates of inflammation. And even at this lowest magnification, you can appreciate there are large macrophages. And if you go to a higher magnification, you appreciate those macrophages as multinucleated giant cells. And there are histiocytes, and then there are lymphocytes. So obviously we are talking about granulomas. And we don't at this time see any necrosis. So these are non-necrotizing granulomas in that linear fissured area of the mucous membrane. And so this is a further higher magnification where you can appreciate those multinucleated giant cells and histiocytes and lymphocytes, and there's no evidence of any necrosis. However, when you see granulomas, your differential diagnosis should include at the minimum these conditions: foreign body, sarcoid, orofacial granulomatosis, fungal infections, tuberculosis, and Crohn's. And a word on TB, typically early lesions, especially in oral mucosa, need not show any caseation necrosis. Caseation necrosis is a more advanced finding, especially in lung lesions and in lymph nodes. So please be careful about not excluding tuberculosis in oral lesions if you do not see any caseation necrosis. So obviously, we have to do some special stains. Of course, if you have a polarizer, and if you do not even have a polarizer at your facilities, you can just use 2 X-ray films. One placed on the slide and one placed on the condenser at the bottom, and rotate them, and you should be able to look for foreign body. If it's crystalline, you will be able to see it in the granulomas. In this case, there was no foreign material anywhere in the proximity of the foreign body in the proximity of the granulomas. We did suggest a panel for ACE enzymes, but this patient did not have any, chest findings, no cough, there was no fever. So although we did ask for ACE levels, the sarcoid was kind of a little down in our differential. We were not too excited about a diagnosis of sarcoid. Orofacial granulomatosis can happen without lip swelling. You could have just isolated areas of lesions in the oral cavity, so it was not entirely ruled out. We had to do a GMS and acid-fast stain to rule out fungus and tuberculosis. And then, of course, based on the patient's symptoms, one, of course, is he's young and abdominal cramping and runny stools. Crohn's had to be in the differential, pretty high in the differential rather. So here's a positive GMS control. And you can see those are just, filaments of Aspergillus. And so we knew our positive control is working. And so this is the case itself. And you can see that's the area of the granuloma. You can see those giant cells and histiocytes. There's nothing inside, so it's negative for fungus. What you see over here, these black areas, is just reticulin fibers. It's, after all, a silver stain, so reticulin fibers are going to pick up and show themselves as dark. But within the granulomas itself, there is no fungus. So this is a positive control for acid-fast bacilli. That's Ziehl-Neelsen stain. And within the circles, even at this lowest magnification, you can appreciate those pink rod-like structures if your computer screen resolution is good enough. And so here are our granulomas, and they are absolutely negative for any acid-fast bacilli. So my sign-out diagnosis was non-necrotizing granulomata, and with a question, rule out Crohn's disease or regional ileitis based on clinical findings. So when the report went to the doctor, he called me back and said, hey, you know what? That's interesting that you put this in your report, because my patient is on methotrexate and on vedolizumab, and he has had a colonostomy a few years ago. And so, that's a monoclonal antibody, which is very selective to integrin gamma 4 beta 7, and very selective for inflammatory conditions of the GI tract. And so I said, really? So I said, do you know where he had his colonectomy done? He said, oh, it was at your hospital. So I pulled up, records, and I was able to get these pictures. of his past surgery. And so, as you can see, this is this guy's resected, terminal ileum with the ileocecal valve and the cecum and his appendix, and with periappendicular fat. And so here are some slides of these organs from the same patient, and this is a cross section of the appendix, just filled with lots and lots of neutrophils. So that was an appendix ready to burst with abscess formation. And so the ileum itself was unaffected. You can see those, villi, long finger-like projections. So there's no villus atrophy at all. It's a normal ileum. And you can see there's no inflammation in the muscularis mucosa. And so here is the ileocecal valve. And, so unlike the ileum, where you can see those, long villus projections of the mucous membrane, at the ileocecal valve, they're all totally flattened. So there's total absence of the villi, and there's a lot of inflammation, and most consequentially, you see transluminal granulomas. You can see granulomas extending almost from the surface all the way to the serosa and into the fat over here. And even at this lightest of magnifications, you can appreciate those giant cells right there. So these are granulomas even in areas of the strictures, and these are granulomas even in the lymph nodes in the pericolonic and periappendigeal lymph nodes. So the diagnosis at that time was severe Crohn's colitis with ulcers, strictures, and abscess formation and serositis, and appendicitis with serositis, and a lymph node with non-necrotizing granulomata. So the reason I want to share this case was, you had two cases of ulcerative colitis, case 1 and case 2, with the oral manifestations including pyostomatitis vegitans, linear fissures and grooves, cobblestoning of the oral mucosa. And in this case, it's a diagnosis of Crohn's in a much younger patient, and presenting in the mouth as a solitary linear fissure. And the biopsy findings were also discussed in both these cases. So as we know, Crohn's can affect anywhere from the oral cavity all the way to the end of the GI system, while ulcerative colitis in the GI system is more a disease of the colon, and especially the distal colon and the rectum and the anus, while Crohn's is, a full thickness condition. Ulcerative colitis is more of a superficial condition affecting only the mucous membrane of the GI tract. So very different conditions, but oral manifestations can overlap a lot. None of these oral findings are selective for either Crohn's or for ulcerative colitis. So please bear in mind these oral manifestations of these inflammatory GI conditions. Okay, so let me have a sip of water. Thank you. So this is our next case, very interesting case again, and I'm happy to share this with you. I do not have a clinical picture on this case, but I don't think it would have made much of a difference because the findings are more interesting so far as the histology and the follow-up of the histology specimen. So bear with me, I don't have a clinical picture. 62 male, tooth number 29. So I'm so sorry, I should have changed this ADA system into the international. So 29 is going to be the lower right quadrant, okay? So the patient had an elevated whitish plaque, and here is the biopsy. I know at this lower magnification, you probably don't appreciate much, but if you watch closely at my pointer, you'll see the superficial lamina propria. There's a lot of, homogeneous eosinophilic material, especially towards the right side over here and there. And you see a lot of inflammation as well. And a little more higher magnification, you can see where I am. The dermal papilla show a lot of this homogeneous eosinophilic material. And there seems to be some destruction of basal keratinocytes over there. And there's some inflammatory cellular infiltrate as well in the lamina propria. So when you see this kind of a homogeneous eosinophilic material, obviously Congo red stains come out, don't they? So this was Congo red positive, and you know where I'm going with this. So you can put down the diagnosis on the paper pads next to you and give yourself a pat. And this is through polarized light microscopy. You can see areas of that Congo red staining exhibit an apple green birefringence. So you can see this is in contrast to the collagen. You see the collagen over here at the bottom? This is not apple green. This is more whitish in color, while the amyloid is apple green in color. And so the diagnosis was amyloidosis with a concern that, please rule out systemic amyloidosis. And, so we got to take a look at different kinds of amyloidosis before we, it's too simple, isn't it, so far? But let's see how we go with this case. So here's a list of different types of amyloidosis. Localized cutaneous, we'll talk about that in some detail. And light chain amyloidosis, we typically see this in plasma cell dyscrasias, especially in multiple myeloma, where the malignant plasma cells are just cranking out a lot of immunoglobulin. So that's AL or primary amyloidosis. And then you can see AA or secondary amyloidosis in chronic inflammatory conditions, ranging from osteomyelitis to TB, sarcoid, rheumatoid arthritis, inflammatory bowel disease. So the list is can be pretty extensive. And then you have hemodialysis associated amyloid deposition. Some people who are genetically prone to deposition of amyloid as they grow older, what we call as hereditofamilial amyloidosis. And so in this case, the question was, like, what kind of amyloidosis are we looking at on this gingival biopsy? And so this specimen was sent to the Mayo Clinic in Rochester, Minnesota. And they did a lot of fun stuff in teasing out this eosinophilic areas from the biopsy specimen sent to them. That's a paraffin embedded specimen. And they figured out that the peptide profile is consistent with keratin type amyloid deposition. So they were able to detect keratins 5 and 14 in this mix of tissue that they extracted from the superficial lamina propria. And they made a comment saying that keratin 5 and 14 related amyloidosis is typically limited to squamous epithelium and is because of inflammation and degenerative conditions that damage the basal keratinocytes, resulting in amyloid deposition. So this is a very interesting finding. It's not associated with systemic amyloidosis. And so this is a condition known as localized cutaneous amyloidosis. This is probably the first case noted in the mouth. So we could call it as localized mucosal amyloidosis. The identity of fibrils in this condition is not known. And so, this is a very interesting case. It's a very rare condition. And so, we could, some people even call this as lichen amyloidosis. It's just because of a combination of inflammation that you see in the lamina propria with degeneration of basal keratinocytes, and then there are antibodies to keratin proteins. And so this entire, it is purported that this entire interaction of inflammatory cells and antibodies, breakdown of keratin, results in this localized deposition of amyloid. So just to let you know, if you find this in some of your biopsies, probably what you're looking at is lichen amyloidosis or cutaneous mucosal amyloid against anti-keratin antibodies. So a very unique case. I thought I should share this with you. And so I'm going to push things up a notch over here. So yeah, in the previous case, the diagnosis was pretty straightforward, amyloidosis, but the real issue was not the diagnosis of amyloidosis, but to find out what kind of amyloid it was. And interestingly, it turned out to be Lichen amyloidosis, which is, I don't think there are any reports in the oral mucosa. There are many reports on the skin condition, however. Okay, so as I said, I'm going to move things up several notches, in fact, over here. So if you know this diagnosis based on the clinical findings, you should give yourself a double pat on your back. So we have a 19-year-old male, and he happens to be son of a dental hygienist. So, dental hygienists are so good at doing a thorough intraoral exam. And this happened, the hygienist happens to be his mother. And so she's so concerned that there are these firm lesions on the marginal gingiva of her son. And so she tries cleaning the teeth, and these lesions just will not go away. And for some reason, the clinic that she was working in, the doctor had prescribed this young man antivirals for cold sores, a totally empirical treatment, and obviously it was ineffective. And so a biopsy was taken for and sent to me for histopathological examination. So here are a few pictures. And if you observe very closely at the marginal gingiva, follow the pointer, and you'll see this very rough margins of the gingiva. And you can see it's kind of rolled over here as well. And interdental papilla. And again, you can see this almost cobblestone-like appearance or rough granular appearance of the marginal gingiva. And here's another shot. You can see over here, this one, and around this tooth over here, there as well. There are several other pictures that the hygienist took with her cell phone after a second or third cleaning. And you can see this over here. It's almost like yellow red with elevation of the marginal gingiva. You can see this almost like a mass over here. Yellow red in color. You can see that over here on this side. And you can see this. It looks almost as if there's fibrin or pus. And you can see these red areas. It looks very granulation tissue-like. But when palpated, if you palpate granulation tissue or pus or any inflammation, it's going to be soft. This was firm in consistency. So very unusual. And so here's another picture. And all this was very firm in consistency. And so very unusual for inflammation, isn't it? And so a biopsy was taken. And so I got this biopsy almost immediately after that amyloid biopsy. And so when I looked at this, I said, uh-oh, another case of localized amyloidosis or what? So here are some H&E pictures, and you can see again that same amorphous homogeneous eosinophilic deposits in the superficial lamina propria. You can see that here as well. And then another area here and here. And so when I ran a Congo red, this was totally negative. And so I made a suggestion. I did not run, I should have probably run a PTAH, but I was pretty sure about what I'm looking at in the absence of Congo red. I signed it out as deposits of fibrin. And, why is fibrin being, why is fibrin building up in the connective tissue over there? So I said, evaluate the patient's serum for plasminogen activator inhibitor activity, as well as plasminogen activity. And so these are screenshots of the report itself. And you can see the plasminogen activator inhibitor is normal. So the function of plasminogen activator is not being inhibited. But look at the activity of plasminogen itself. The normal range is supposed to be from 71 to 144%, while in this patient, the plasminogen activity was only 24, like about 1/3 of even the lower range of normal in this patient. So, you know the function of plasminogen. If you go to the mechanisms of hemostasis, the primary mechanism, of course, is formation of a clot. And so we call that the coagulation system. And as coagulation is going on, simultaneously, you have the protein C and protein S system that regulates the size of the clot. And so it keeps the clot only to the area of the defect. So you don't want the clot, you know, overwhelming our vascular system. That's too bad. You could end up in conditions like hypercoagulability or DIC. So the regulatory system confines the clot to the wound itself. And so after the wound heals, the clot has to be broken down. And so we call that as the fibrinolytic system. And so some of the chemicals that take an active part in breakdown of the fibrin polymer is plasminogen. So you have plasminogen activators that convert plasminogen to plasmin, and plasmin breaks down the fibrin polymer to fibrin degradation or fibrin split products. And so the clot breaks down. And so the result is normal tissue after wound healing. But in our patient, there was a deficiency of plasminogen activity itself. So when there's a deficiency of plasminogen, the amount of plasmin that forms is reduced. And so you do not have enough plasmin to break down any clot that's formed. So every time the mother would do a cleaning, there would be a wound, and the result would be a formation of a clot. But since this young man had a deficiency of plasminogen, the clot would not break down. And so the result would be those hard yellow-red masses on the attached gingiva, which were essentially just collections of fibrin. So if you know the diagnosis and you put it down on the piece of paper, you know, give yourself a double pat. So, you know, when we feel these masses on the gingiva, they feel firm. So, you know, the people who first described this condition felt that these were as firm as pieces of wood. And so they, you know, compared this with coal that's formed from pressurized, you know, wood, what we call as a lignite. And I'm sure you people are, you know, very well aware of Navali Lignite Corporation, where they pull out this lignite coal, isn't it? So there are, you know, coal is of 3 different types. The bituminous is the big black one that we see. Peat is more because of decomposed animal and vegetable matter. And lignite is somewhere in between. It's more because of a lot more of, you know, plant matter. So this is a diagnosis, you know, known as ligneous gingivitis. More cases show presentation in the eye, where it's known as ligneous conjunctivitis. So once again, if you have diagnosed this correctly based on the findings, please applaud yourself and give yourself a pat on the back. And so, you know, I informed the doctor about this condition, and he said, oh, you know what? This kid has been seeing an eye specialist for several months. But if you look at this, the eye specialist, the ophthalmologist, has misdiagnosed this entirely. He calls the lesions in this, I do not have pictures of the eye in my patient. But anyway, so I've you know, cut and pasted parts of the communication from the ophthalmologist report, and he called these as flictanules. So if you know, Google up flictanules, these are, you know, little nodules inflammatory response typically happening on the cornea and conjunctiva. And so he's saying, I'm going to, and look at the words, like, I'm going to hammer it with Durezol. It's a topical ophthalmic steroid. And it did not work. They came back. And he said, I'm going to have this patient worked up for TB or syphilis. Imagine a 19-year-old child. Or give him tea tree oil shampoo. So he's totally barking up the wrong tree. And then he says that the lesions have come back. Now they are on the right side of the eye, on the cornea, near his lid margin. The Durezol is really not controlling it. And so he's been going on totally up in a wrong direction. That, it could be herpes. This child was born vaginally, so maybe the mother had type 2 herpes. So I'm going to give him acyclovir. And so he was just going in a totally wrong direction with the ocular lesions. And lucky for the child that the dentist performed a biopsy, and I was able to view that biopsy and provide a more accurate diagnosis of ligneous gingivitis. And therefore, it also made a comment about ligneous conjunctivitis. So bear this in mind. It's not unusual. There are several reports in literature on these ligneous lesions in the oral mucosa. And so it's something for you to keep in mind. A simple test to detect levels of either plasminogen activator inhibitor or plasminogen activity itself should get you to the right diagnosis. So I thought I should share this interesting case with you. So there were 2 lesions of the lamina propria of the gingiva. One turned out to be keratin amyloid, and the second turned out to be ligneous gingivitis. Okay, so I'm going to move in a totally different direction now. Give me a second. Thank you. So this case is of a 48-year-old female, and she's complaining of pain and swelling of her upper lip. Now, this has been around for a few weeks, so it's not an acute condition. And she's been, self-medicating herself with lip balm and Blistex and chapstick. And however, she's found no relief with self-medicating. And so the doctor performed a biopsy. And so here you can see there's a swelling of the lip. There's a lot of fullness, and she has some pain. There's some crusting, some exfoliation. So that's not herpes, it's just exfoliation, and there's no angular cheilitis, it's just exfoliation. And so, when you get this kind of lip swelling, which is more diffuse, it's not a mass, so it's not a tumor. So your differential is going to start first with angioedema. It's easy to rule out angioedema because angioedema is type 1 hypersensitivity. It's acute. Patient is not going to have this problem for several weeks. It's going to be like an acute, immediate attention requiring condition. There are several different kinds of angioedema, right from Ig mediated to angiotensin converting enzyme, deficiencies to complement system activation to, taking type 2 ACE inhibitors. So, but whatever the reason, angioedema is always acute. It's not several weeks in duration. Orofacial granulomatosis with or without inflammatory bowel disease and cheilitis granulomatosa is definitely in the running. They don't tend to cause that much of pain, so it was somewhat unusual for that diagnosis, but still in the differential. Cheilitis glandularis or Bale's disease, especially the acute form, you get these little blocks of the labial minor mucus glands, and it's very tender, very painful. And if you squeeze, you can exude out a little pus from the openings of the minor ducts that we did not see in this patient. And then, of course, we have to think of candida affecting the lips as well. However, here's the biopsy. When I looked at this picture, I really was quite stunned. And even at this lowest of magnifications, you see the surface epithelium there, you see a grunt zone of collagen, and then you see a lot of vacuolated cells. And this, of course, is deep down. You can see this thing is quite infiltrative. Between collagen, it's going all the way down. It's quite a deep wedge of the biopsy. And you can see these, vacuolated cells going all the way down between collagen fibers. But there are these huge globules, these huge holes as well in the connective tissue, surrounded by compressed basement membrane-like material or collagen, more likely to be collagen. You can see that over there. So here's a higher magnification, and you can see these, vacuolated cells. And that's one of those huge vacuoles with compressed collagen around it. And over here, so these do look superficially like lipoblast with crenated nuclei, multiple vacuoles. And so such a rare thing, for this to be a well-differentiated liposarcoma, and especially this kind of a diffuse presentation on the lip. And, those tend to be more visceral tumors in the abdomen or in the thigh, retroperitoneum. And although there are cases in the head and neck, but very unusual presentation. But however, we cannot rule it out entirely. The other differential was going to be exogenous lipid material, but the question is where from? And with a florid macrophage response, what we call as lipid granulomas. And so the next best thing is to, figure out, like, is this a liposarcoma, or are these macrophages with some lipid material inside them? So S100, if this was fat, you can see some native fat, So typically S100 would delineate the adipocytes and fat droplets, and that is only adipose tissue. I shouldn't just use fat over here so easily. And you can see native adipose tissue. There's a circle of brown around them. You can see that here as well, and here and there. So it's very sparse. So obviously this is not adipose tissue. Rules out a liposarcoma. And CD68, it's a histiocytic macrophage marker, and all the cells are, positive for CD68. And so my diagnosis was that of a silicone granuloma. So, silicone gel, this is at least, information from the US. Silicone gel has been approved for breast augmentation, but has not been approved for any other cosmetic use. And so more than likely, this lady has gone outside the US, either to Mexico or some other country, and she's tried to, have a surgery for getting a more full upper lip done. And now she's having this problem, what we call as silicone granulomas. So silicone gel is hydrophobic, and obviously it's fatty. So it doesn't mix with water. It's non-degradable. It doesn't dissolve in the tissue. It's a volumizer filler. So it just, fills up and produces mass and contour to the tissue. And it dissipates into numerous inactive oil droplets. These oil droplets are engulfed by macrophages, and they often migrate to regional lymph nodes. And granuloma formation can occur even many years after the injection of silicone inside the tissue. So very quickly, a note on dermal fillers. We have these natural fillers. So these are, resorbable. And so they are not volume fillers. They excite the local tissue to produce bone, to produce collagen, and then they get replaced while the synthetic fillers, like silicone, are volumizer. They are hydrophobic, they are non-biodegradable, and that's a problem. And so, there is increased risk of adverse reactions with these synthetic fillers. And so these adverse reactions can range from asymptomatic swelling to swelling with pain, burning sensation, pruritus, erythema, as the particles dislocate and migrate and produce foreign body reactions or granulomas. So, it's very, very important to note that, patients can be poor historians, especially in silicone granulomas. They might have had this surgery many years ago, or, they don't want to express that they have undergone some such cosmetic surgery out of, I don't know, shame or just being shy about it. And so clinical history may be inadequate, or they may not even remember if the history of injection was remote. And the patients may not even remember what material was used for that kind of a cosmetic, upliftment, if you like. And so it could have been many, many years ago. And so it's, these masses of reactive tissue secondary to cosmetic fillers can easily be mistaken for tumors based on their clinical appearance and sometimes even based on their histopathology. As you saw in this particular case, it looked so fatty filled. Superficially or to the untrained eye, can easily be mistaken as a well-differentiated liposarcoma. And so, it's essential to have good knowledge of some of these microscopic appearances and the response of tissue to many of these, cosmetic fillers. And, I would, refer you to, if you do not have other resources, to this website, which is the American Academy of Oral and Maxillofacial Pathology. That's AAOMP.org. And there at the top itself, you'll see one link to an atlas. This was created by Dr. Harvey Kessler from Baylor, and with presentation of cases from many other people. And you can see histopathological pictures at various magnifications of many, cosmetic fillers, as well as bone graft materials especially. So please do use this site. If you see something in your biopsy, the site can help you a lot towards giving you a diagnosis. So in cases where you are not able to establish a diagnosis, you're not able to establish a diagnosis of what the material actually is. There are other physics related things that you can employ, like infrared or Raman spectroscopy or energy dispersive X-ray analysis to arrive at a diagnosis. But by and large, that would not be required if conventional materials have been used. If you look at this atlas or some other resource, you will be able to provide a name to the filler that you see under the microscope. So we will shift gears a little, and I'll talk about two interesting bone lesions. Okay, so the first case is a 26-year-old female, left posterior mandible pain with slight swelling, mobility of a tooth, and she also has a left upper arm mass. So here's the X-ray, panoramic radiograph, and you can see the left posterior mandible. There's a missing tooth, and there are teeth, especially this first molar over here has got almost no bone support. It seems to be extruded, like as if there's some mass at its root that's pushing it out. And you can see these multiple radiolucencies with ragged borders in some areas, and a scooped out appearance at the superior alveolus. And overall, it's more of a permeative pattern of bone loss. So everything is pointing towards a lesion that's not exactly behaving like a benign cyst or a benign tumor. So here's the biopsy. And so more than likely the biopsy was taken from some soft tissue over here. You can see the soft tissue shadow over here. So it was probably this area that was taken out and submitted, and that accounts for a lot of this cross-contamination by inflammation over here. But even at this magnification, you can see there are really large epithelioid cells, huge cells. And so mixed with a lot of inflammation, there's a lot of hemorrhage as well. And if you go to a higher magnification, you'll see those large cells are actually macrophages. You can see the cytoplasm is really granular or foamy. And you can see a lot of inflammation as well, ranging from neutrophils to lymphocytes. And then there's this one interesting thing that showed up, and I tried to look around, and you can see some there as well. So here's a huge macrophage, and inside the cytoplasm of the macrophage, you can see a lymphocyte with a clear halo around it. So it's as if the lymphocyte has been engulfed, but it's just sitting inside the cytoplasm passively. It's not being digested. So this is a phenomenon known as emperipolesis. If you know what the diagnosis is just based on this emperipolesis, please write it down on that notepad and tap yourself again on your back. And so when I saw this histological presentation, I said I have to run a few stains. And so alpha-1 antitrypsin, CD163, CD68, these are all macrophage markers, histiocyte markers. And yes, alpha-1 antitrypsin was diffusely positive among all these histiocytes. And that's CD163. And you can see it's again positive in all these macrophages. So the diagnosis is, it's a histiocytic lesion. When you have a histiocytic lesion, you always want to rule out Langerhans cell histiocytosis. But however, CD1A, which is a selective stain for Langerhans cells, was totally negative. And even then, I did not see any eosinophilic abscesses. However, that is not necessary for a diagnosis of Langerhans cell histiocytosis. If I do see a lot of eosinophils and eosinophilic abscesses, it's very helpful with coffee bean nuclei and linear indentations on nuclear grooves that would all be helpful. But CD1A was negative. And so Langerhans cell histiocytosis was ruled out. So I did S100. And all those histiocytes that were positive for CD163 and alpha-1 antitrypsin were also positive for S100. And so the only condition where the histiocytes are also positive for S100 is, as you know, Rosai-Dorfman disease. It was earlier known as sinus histiocytosis with massive lymphadenopathy. And so in this lady, the left upper arm mass was also biopsied, and a diagnosis of Rosai-Dorfman disease was confirmed. And so if you got the right diagnosis, congratulations. So there's been a recent paper, and I could refer you to Head and Neck Pathology 2020. It's a very recent publication, a multi-center study, probably the largest collection of extranodal Rosai-Dorfman disease of the head and neck. And you'll find it interesting reading with a lot of very good histology and clinical pictures and radiographs on those cases. So there are cases from the sinonasal apparatus as well as from the jaw bones. So it's a good paper of largest collection of cases. So it was first described by one Rosai in Italy in 1969. The etiology is not known. We don't know what causes Rosai-Dorfman disease. It's reported worldwide, so there's no specific predilection. to any particular race. It's a histiocytic disorder. It's locally destructive. Patients can be kids or young adults with fever, weight loss, leukocytosis, and raised ESR. There's a question as to whether this could be an infection, but obviously there's nothing proved that this could be an infection. Patients can have enlarged lymph nodes, but this condition can affect any part of the body. Excuse me. Zoe. I'm so sorry. It's a Saturday. I'm sitting at home and my dog is barking at other dogs that are walking outside. So, okay. So, we know that, this disorder can affect any part of the body. And interestingly, when it affects tissue outside of lymph nodes, 75% of those such cases are seen in the head and neck. And so this is a condition, therefore, that we should all be very, very familiar with and acquaint ourselves with the histological findings. The radiographic and clinical findings can be quite diverse. So the diagnosis is entirely histological. Keep in mind a whole sheet of macrophages. Keep in mind to look for emperipolesis, but once again, a word of caution, emperipolesis is more easily seen in cases that affect lymph nodes. Emperipolesis in head neck cases is very hard to find. Emperipolesis is not unique to Rosai-Dorfman disease. So it's the normal duty of macrophages to engulf and phagocytose. So emperipolesis is a part of inflammation. But if you see it in such a setting, it kind of reminds you of what you need to do, and that is to stain the tissue with a macrophage marker to prove that yes, those are macrophages, and then especially follow up with S100. And if those macrophages stain positive with S100, that nails your diagnosis. That is very diagnostic. Okay, so there's no specific treatment for Rosai-Dorfman disease. Everything from chemo to radiation has been tried, but none of it is really helpful. The results are very variable. So typically it's surgery. That's the main mode of treatment. So wherever you see lesions of Rosai-Dorfman, you excise them, or if you see conditions in the bone, aggressive curettage and scooping out results in control of the disease. In many cases, this disorder is also spontaneously involuting. So spontaneous resolution is seen in a proportion of cases. So that was one bone case I thought I should share with you. Here's the next one. Pretty interesting. 15-year-old female, painless swelling of a right posterior mandible. And so the doctor performed a biopsy of what he thought was a radiolucency. And the biopsy just showed giant cell granuloma like histology. We just, asked for a copy of the CBCT. And so if you look at this panoramic rendition of the CBCT, you can see this is where the biopsy was taken from, that radiolucency over there that showed the giant cell granuloma of like histology. But immediately, there are some things that stand out which asked for further testing. So, the doctor could see only this, and he totally blanked out, totally missed out on what else is going on in the jawbones over here. And you can see there seems to be a unilateral thickening of bone on the right skeleton, facial skeleton. You can see the right mandible, density of bone has increased. You can see the right maxilla. You can see the right antrum is reduced in size. You can see the maxillary bone is thick. Palatal bones are thick. You can see the sphenoids are thick, all the way going over here. And so we asked for medical grade CTs, and you can see in both the coronal as well as in the axial views that there's a displacement of the sphenoid sinus, thickening of the pterygoid process, thickening of the maxilla, and you can see this entire thickening of the calvarial bones as well over here, thickening of the right mandible. The inferior dental canal has been pushed way down and is so small. And in the axial view, you can see this ground glass-like appearance with swelling of the maxilla. The mandible is thickened. So this is that radiolucency from where the biopsy was attempted. And so when we looked at the 3D rendition of the CT, we saw this over here. This reminds us of, dirty candle wax, right? You place a candle, the wax melts, and it starts dripping along the sides of the candle. So this is very, very unique to a bone condition. I will get to that. So this is what we call as a dripping candle wax-like appearance, as you see over here in this patient. And so we knew what the diagnosis is based on this finding in particular, the dripping wax appearance. And so this condition typically affects the long bones. So there are very few cases affecting the jaw bones. Interestingly, after this case, I had 2 more cases. So if any of you have this, condition popping up in your services, or if you diagnose patients and if you have good documentation, I'd be happy to join in publishing some cases with you. I got 2 more cases with me of this condition. And so when we looked at the long bones, you can see in the femur, there is, opacification of the epiphysis and the entire, diaphysis. Typically the diaphysis should be marrow, like as you see over here, but you can see this entire thickening of the cortex with opacification of the diaphysis. And so this is going to be the tibia, and you can see in the tibia also, look right over here, epiphyseal opacities. See that affecting these distal metatarsals. You can see the entire toe is curved towards the left. And so this is a condition known as mulariostosis. And so very interesting. It belongs to the family of sclerosing bone dysplasias. I'm sure you're more familiar with conditions like pycnodysostosis or even osteopetrosis. So this typically affects the appendicular skeleton. Very few cases have been, reported in the jaw bones. And so this is one of those cases. And so this is a word derived from melos or limb and Rhine, as in the river Rhine, although the spelling there is a little different, which means flow. So it looks as if the limb is flowing. The result is dripping candle wax-like appearance. So the diagnosis is entirely radiographic. So there's no specific histological finding. There is no specific clinical finding except the patient is young. And because of this, abnormality of bones, there can be skeletal deformity in the lower limbs especially. And so 1 in 1 million incidents, no genetic predilection, case onset is in early childhood, and most cases are before 20 years of age. And lower limbs, unilateral. However, it was interesting that in this patient, the limbs that were affected were on the left side, and the jaw bones and the craniofacial apparatus that was affected was on the contralateral side. And so in this condition, blood chemistry and serology is normal. So no abnormal calcium levels, no parathyroid hormone changes, no vitamin D changes. So blood chemistry is totally normal, phosphorus levels are normal. So patients can, present with consistent chronic pain, shortening and angulation of limbs. And that's because of these changes that you see in the epiphyseal plates with premature closure of the epiphyseal plates. Patients complain of joint stiffness, and there's limitation of movement with muscle atrophy. So it's almost like they're suffering from polio, if you like. And except that in polio, you do not have any pain. And so polio, again, can be unilateral. Of course, there could be bilateral also. So only 9 jaw cases have been reported. And so I have 2 more cases. If anybody else has this in your collection, I would be happy to join with you in another publication. So in the jaw bones, the features can be quite variable: pain, sensory disturbance, displacement of teeth, widening of PDL, bone expansion. But the most critical finding is when you take a 3D CT, you're going to see that dripping candle wax-like appearance. And always follow up with radiographs of the lower limbs, because no matter your jaw findings, there will be disease of the lower limbs. So those were, of course, a few words. Symptomatic care, surgical correction. Of course, surgical correction must be attempted only after a patient attains skeletal maturity. And the disorder slows in adulthood with often spontaneous cessation, so it's not progressive. And so patients can otherwise live a full, healthy process is good. So those were 2 interesting bone cases that I want to share with you. And now we move on to a collection of salivary tumors. Thank you. So this is going to be the last part of this talk, but I do have a collection of salivary tumors that I would like to share with you. Some just because they are unique tumors. One is a case of an adenoid cystic carcinoma that I want to share with you, just because the histology is so classic, and especially the immunohistochemical findings are just so classic that I thought, this is something that could make for good teaching, and therefore you should probably have those pictures. So here's the first case, a 60-year-old male, slowly enlarging asymptomatic mass, left parotid region, several years duration. And so you can see that the lower lobe of the parotid, superficial lobe, and right below the ear, near the angle of the mandible. And this is just pre-surgery, planning the incisions. And this is during the surgery, and you can see the mass is affecting the superficial lobe, very well circumscribed mass. And the entire superficial lobe was removed, and you can see the facial nerve with all its branches are intact. And so this is the mass that was removed and bread loafed. And these are the slices of the loaves after the tumor was resected with the surrounding normal tissue. And so you can see it's circumscribed, but even at this low magnification, you can see there are large supposed pseudocystic cavities with some eosinophilic material inside, a lot of hemorrhage, a lot of microcystic areas, fatty degeneration. And of course, you know what this is, right? Nuclear palisading with verrucate bodies, looks like Antony A tissue with all these verrucate-like areas. And so putting this with a lot of cystic areas, with a lot of hemorrhage, fatty degeneration, with all this, you can put the diagnosis down. Probably you may be right or wrong, I don't know. So at least at this step, when I looked at all this, I said, Am I looking at a schwannoma with ancient or degenerative changes? This would be a pretty straightforward thing until I looked at some of the other sections. You see, there are multiple pieces over here. So each one goes into a different slide, like A1, A2, A3, so on and so forth. So when I looked at other slides, I started seeing some duct-like areas. And you can see there's nuclear palisading here with Verroque areas, and there's a duct over there. And in another section, you can see a lot of glandular tissue, a lot of ducts, and a lot of other, epithelial cells. And you can see that nuclear palisading and collagen over here. So, there have been reports of schwannomas with glandular differentiation. So I thought, could this be a schwannoma with glandular differentiation? So I said the only way, of course, this is in the product gland. I should first consider salivary tumors. And of course, it's a benign, well-circumscribed mass. So obviously, majority of those kind of tumors are going to be representative of pleomorphic adenoma. And, as one of my other senior colleagues used to say, pleomorphic adenoma, you have seen one pleomorphic adenoma, you have seen only one pleomorphic adenoma, which what he meant was no pleomorphic adenoma is histologically like another pleomorphic adenoma. Each one is so distinct in its histological presentation, and that's why they are pleomorphic. We call them pleomorphic based on their varying morphology when we see them under the microscope. So I really couldn't at this point rule out a pleomorphic adenoma. So we have a dilemma now. Are we looking at a schwannoma with glandular differentiation and ancient change, or are we looking at a pleomorphic adenoma with schwannoma-like features with nuclear palisading and Antony A-like areas? So what's next? Bring out the markers. The problem is, schwannomas and pleomorphic adenomas are both S100 positive. Schwannomas and pleomorphic adenomas are also GFAP positive. The only thing that will help me exclude schwannoma would be P63, which is a myepithelial and basal cell marker, which would be positive, obviously, in a PA, but would be totally negative in a schwannoma. So here are the pictures. And right at the bat, off the bat, you can see the nuclei are intensely positive for P63. So this cannot be a schwannoma. So this is the diagnosis, pleomorphic adenoma with schwannoma-like features. And so I could direct you to this paper, Divergent Schwannoma-like phenotype in a pleomorphic adenoma. And so look this up, and you can read a lot more about this. The important thing about this case is that when you are dealing with pleomorphic adenomas, please be prepared to be surprised. Every pleomorphic adenoma is a unique entity histopathologically. No pleomorphic adenoma is like another pleomorphic adenoma. And so there are a range of histological features, and in many conditions, especially like in this one, I had to, resort to S100, GFAP, and P63 to rule out a schwannoma. So this is a case of a divergent schwannoma-like phenotype in a pleomorphic adenoma. Okay, so let's move on to our next case. 70-year-old male, swelling, slow growing, left vestibule and cheek, and complaints of some discomfort. So yes, so this is the adenoid cystic carcinoma. I mean, what is so big about an adenoid cystic carcinoma, and why am I doing this? The only reason I'm sharing this case with you is because of the classic histology and classic immunohistochemical findings. Just makes for a great teaching case. So in these 4 pictures, you can see it's more of a tubular pattern of an adenoid cystic carcinoma. And if you look at these 2 arrows over here, of course, you can see a lot of mitotic figures. This thing is quite revved up. It is mitotically active. And yeah, so coming back to these 2 arrows, you know, an adenoid cystic carcinoma is a tumor composed of 2 different cell types. Luminal cells that are ductal. And so that's the luminal cells. You can see they are more columnar. And then abluminal cells that are on the outside, which are more, smaller and angulated nuclei, which are myoepithelial in origin. So ductal and myoepithelial. So 2 different cell types. And you can see that clearly in this picture over here. You can see that here as well. And you can see that over here as well. That's the abluminal or myoepithelial, and these are columnar or luminal cells. And these were other parts of the tumor, what we know more colloquially as Swiss cheese-like appearance, or the cribriform pattern. And in this case, however, there were some vacuolated cells. They have been described in adenoid cystic carcinoma. So you can see in the picture on the lower right, a lot of these vacuolated cells. And you can see oncocytic metaplasia over here. And then I wanted to share pictures of perineural as well as intraneural invasion, as you see in this picture on the bottom over here in the middle. And what was most fascinating was this, distinct staining pattern using P63 and CD117 or c-KIT. And that's why I wanted to share this case with you. P63 is a basal cell and myoepithelial marker, and you can see it is delineating the nuclei of the abluminal cells. So clear. And the luminal cells are entirely negative, while CD117 or c-KIT stains the luminal ductal cells, while the abluminal cell is totally negative. So this is in the tubular pattern areas, and this is in the cribriform pattern areas, where you can see the abluminal cells stained with P63, and the same thing at a much lower magnification, same area, you can see the luminal cells are c-KIT or CD117 positive, and the abluminal cells are totally negative. So I want to share these histological findings of a very nice case of adenoid cystic carcinoma with you all. So this is an adenoid cystic carcinoma with tubular and cribriform features with classic P63 and CD117 immunohistochemistry pattern or staining. And so this is the immunoprofile of adenoid cystic carcinomas. I rely mostly on P63 and CD117 if I'm in any confusion. And the only thing that would overlap histologically with an adenoid cystic carcinoma in cribriform presentation would be a polymorphous adenocarcinoma, what we used to call previously as a polymorphous low-grade adenocarcinoma. The most recent WHO classification no longer calls it a low-grade adenocarcinoma. We just call this as polymorphous adenocarcinoma, within brackets, low-grade or high-grade, and we'll talk about that a little later. And so, in polymorphous adenocarcinoma, P63 is inconsistent, even CD117 is inconsistent, and P40 is a more specific myoepithelial marker than P63. So in POGAs, this is a tumor of more basaloid cells. And so P63 is a both basaloid and myoepithelial marker, while P40 is only a myoepithelial marker. and obviously it would be negative in a POGA. And so, all the abluminal cells are going to be positive for muscle markers like SMA and HHF35 in adenoid cystic carcinoma. In polymorphous adenocarcinoma, since there's no contribution from myoepithelial cells, all muscle markers and P40 are going to be negative. So let's move on. These are two interesting cases of, I'm going to show two cases of same salivary gland tumor. Case number 1, 62-year-old male, mass of the left lower lip, asymptomatic and slow growing. And here's the histology at varying magnifications. You can see there's a lot of normal salivary gland tissue over there. And you see this small tumor over there. And you can see tumor cells over here. There's a lot of, gap in the tissue there. However, there's a lot of collagen as well. And so you can see a lot of mucus pooling inside over here. So very superficially, one could mistake this for a mucoepidermoid carcinoma. And you can see a lot of collagen over there. So, one could think very superficially, am I looking at a sclerosing mucoepidermoid carcinoma? And if you go to higher magnifications, you can see a lot of mucus over there, amphiphilic cytoplasm, large prominent cells, almost epithelioid cells, if you like, hobnailing, papillary projections, microcystic areas, and larger cystic areas filled with mucus. So, we are looking at possibilities like, sclerosing mucoepidermoid carcinoma, actinic cell carcinoma with papillary cystic or microcystic and cystic areas. So you got to bring out the stains. This tumor was positive for S100, and you can see normal salivary tissue when you compare this in other areas of the same slide. Normal salivary tissue is negative for S100. And you can see inside the ducts, there's some tumor cells that are positive for S100. And this tumor was also diffusely positive for mammoglobin. And if you see that mucus-like areas within those cystic cavities, they are also densely positive for mammoglobin. And so here's a normal unaffected salivary tissue in the vicinity of the tumor, negative for mammoglobin, but there's a nest of tumor cells inside the duct, inside a normal duct, and you can see that is positive for mammoglobin. And so P63 is negative. And in contrast, if you see the normal salivary gland tissue, P63 is positive, just because normal salivary gland do have around the ducts as well as around the SNI myoepithelial cells or the basket cells. So P63 is positive in the normal tissue, but is negative in this tumor. So here's a second case of the same condition, 32-year-old female, lower lip mass. The clinical impression on the lower lip, when you have something like this, your first impression is going to be a mucocele. So when this was excised, this is the lowest magnification, and progressive increases in magnification. You can see it's much more cellular, but the whole thing seems to be compressed. And you can see here as well, and over here, you can see even at this low magnification and then moving on to a higher magnification, you can see these are quite epithelioid cells with microcystic areas. And so obviously the concern was that this is not a mucocele, it's much more cellular, and could this be a mucoepidermoid carcinoma? Since that happens to be one of the most common malignant tumors in minor mucous glands. And so a mucicarmine stain was done, a PAS was also done, but you can see this is normal tissue over here. So mucicarmine and PAS has to be detected intracellular. It cannot be mucin that's extruded out. So to diagnose a mucoepidermoid carcinoma using mucicarmine, the mucin should be within a cell. And so that's normal tissue over here. And you can see the lobules of minor mucus glands are stained positive with mucicarmine, while the tumor cells are entirely negative. It's only whatever mucin is pooled into the cystic lumen, if you like, is positive, but the cells themselves are totally negative for mucicarmine. And so you can see that here as well, it's totally negative for mucicarmine. And even the PAS, you see the cells themselves are totally negative for PAS. It's only the intraluminal contents of mucin that is positive for PAS. So the next thing was to run those usual markers. P63, you can see this is a duct, a normal duct of normal glandular tissue. It's positive, but the tumor itself is negative for P63. Just a brown blush, that's totally negative. And S100, interestingly, you can see the duct, the normal duct is negative, but the tumor itself is positive for S100. And mammoglobin, if you see, I've just boxed in this area, and this is the higher magnification. You can see the duct, the normal duct is negative for mammoglobin, and as it converts into a tumor, the tumor itself becomes positive for mammoglobin. So this is the immunohistochemical range of markers that we have over here, and the diagnosis is of a mammary analog secretory adenocarcinoma. And I'm not going to go into the details of this table over here. I will leave this with you guys. I guess this presentation is being recorded, so you will have an opportunity to look at this table. So mammary analog adenocarcinoma, secretory adenocarcinoma is a low-grade malignancy. And it has similarities to secretory carcinoma of the breast. And it has a very translocation resulting in a fusion gene known as ETV6 and TRK3. It's because of translocation from 12 to 15 from the short arm at location 13 to the long arm of 15 at location 25. And so it's quite likely that most cases before this was established as a specific entity were diagnosed as zymogen poor ethnic cell carcinomas. And so obviously, since I've used the word zymogen poor ethnic cell carcinoma, I should show you one case, so hang on tight. So the mammary analog secretory adenocarcinoma has a slight male predilection, mean age of 46 years, and affects the parotid gland most commonly. And some authors insist that a FISH or RT-PCR for the ETV6 translocation is absolutely necessary for establishing a diagnosis of MASC, that's mammary analog secretory carcinoma, while some others feel that just using the appropriate histological immunohistochemical stains, like how I showed you, P63 negative, S100 positive, mammoglobin positive, you can rule out all other tumors, and just by IHC alone, you can establish a diagnosis of mammary analog secretory carcinoma. And so if there is any suspicion of zymogen poor ethnic cell carcinoma, you could use DOG1, and so I'll come to that when we speak about that entity. But absence of DOG1 staining will totally rule out zymogen poor ethnic cell carcinoma. So mammary analog secretory carcinomas are treated by just resection with clear margins. Radiotherapy is, the role of radiation is uncertain. This tumor follows an indolent course. Majority of cases, there's no evidence of disease. Mean survival is 92 months. And there, however, have been reports of 3 cases of the parotid gland with high-grade transformation. And so that paper is by Skalova, who is, the person who actually reported the first cases of mammary analog secretory carcinoma and gave it the name also. She's credited with describing this entity among salivary gland tumors. So let's look at the next case, a 58-year-old female, slowly enlarging left parotid mass, asymptomatic. A previous biopsy was attempted, and you can see the site of the previous biopsy from the scar over here. And so here's the incision that's being planned now. And so you can see this mass is entirely within the superficial lobe, and that's a facial nerve, and the deep lobe is spared entirely. And so this is the tumor that's been excised with portion of the cheek as well, where there's that defect. And now the tumor is entirely removed, so the skin flap is clean. And that's a defect of the previous surgery where there was a scar. And so the whole thing is rotated, and a drain is placed for removal of any accumulating post-surgical edema. And so here's the tumor, and that's a normal tissue around it. You can see a lot of lymphocytic infiltration, what we call as tumor-associated lymphoid proliferation. Question is this tumor-associated lymphoid proliferation, or is this a tumor within intraparotid lymph node? Here are sequential higher magnifications, a lot of lymphocytes, and you can see tumor over here. Even at this lowest of magnification, you can see diverse morphology of the tumor, if you like. Some areas are solid syncytial sheets, as you see in these higher magnifications at the bottom. In other areas, you can see numerous holes or microcysts, and so those are those microcystic areas. And in other areas of the tumor, you can see much larger cysts. You can see papillary projections as well. So the thinking was, are we looking at multiple histological patterns, with microcysts, macrocysts, papillary cystic areas? You tend to see that in actinic cell carcinomas. And so looking at, there's a lot of evacuation among many of these cells as well, amphicylic cytoplasm. Couldn't pick any clear zymogen granules. PAS was not again showing any significant amount of zymogen granules. And so the question was, are we looking at another case of mammary analog secretory adenocarcinoma? And so, however, S100 was negative and mammoglobin was also negative. So asked for deeper cuts on more tissue. And then we saw this one island over here with clearly what looks like intracytoplasmic peppered zymogen granules, which were PAS positive and diastase resistant. And so this is an example of a zymogen poor actinic cell adenocarcinoma. So as I said, most cases before Scalova's diagnosis of mammary analog secretory carcinoma were probably diagnosed, especially in minor mucous glands, as zymogen poor actinic cell adenocarcinomas. So routine cases of actinic cell adenocarcinoma, the diagnosis is straightforward. You see lots and lots of zymogen granules that are PAS positive and resistant to diastase digestion. You see a lot of tumor-associated lymphoid proliferation. There are, classic histological variants from solid type to microcystic type to cystic type to papillary cystic type. And then on the extreme range, you're going to see dedifferentiated actinic cell carcinomas, which are hard to diagnose. Immunohistochemistry is not required, but as I said, if there's any confusion in zymogen poor actinic cell carcinomas with mammary analog secretory carcinomas, if you use DAG1 stain, it typically it stains the apical portions of the cells intensely in actinic cell, while that's negative in mask. And of course, actinic cells are also negative for S100 and mammoglobin.
Hi, sorry, I think there is a technical glitch from Dr. Rawal's side. Kindly hold on for a second. We will get this right. Thank you, participants, for your patience. Just hold on for a few minutes. We're just trying to get it right, so kindly hold on.
Oh, yes, I'm back again.
Yes, sir. Thank you, sir.
Okay, I don't know why this is happening, but I'm glad that we are. Can you see the screen now?
Yes, sir. Go ahead. Please go ahead. Perfect.
All right, yes. So there are also muscle markers negative, P63 negative, and actinic cell adenocarcinomas also do not have that 1215 NTV6, ETV6, and KR3 translocation. Okay, so nearing the end of my presentation, 57-year-old female with a soft palate mass. It was measuring about 1.5 to 2 centimeters, several months duration, and the patient was asymptomatic. So a surgeon had attempted a previous punch biopsy, and you can see this is the excision biopsy specimen, and you can see that hole in the center there. And so a punch biopsy was taken over there. It was very superficial, and it was hard to establish a diagnosis. So I had said that it's a tumor. Most likely salivary gland in origin, and it's hard to tell what it could be. It could be benign or it could be malignant as well. So why don't you do a deep excision for clear margins and send me the whole sample? And so this was the second biopsy, and with the intact specimen, and you can see that's the hole where a punch was taken previously. And here's the lowest magnification, and you can see all this tissue over here where the punch was inserted. But luckily, the excision does show, what does appear to be clear margins. You can see normal salivary tissue over there and normal margins on either sides, and the deep margin also appears to be clear. And you can see the tumor is very cellular. And here are some photomicrographs of different areas of the tumor. Very cellular, syncytial sheets of cells, many clear cells, a lot of cytoplasm. And in some areas, I could see what looked like, very superficial resemblance to renal glomeruli. You can see that even over here, with the Bowman's capsule and the glomerulus, it's just looking like that. And you could see other areas, that's a nerve fiber with perineural tumor cells. And then if you look at this island, higher magnification, I started looking at some unique nuclear features. Overlapping of nuclei. You can see that, the nuclei are just falling over each other over here. And what we call as orphan nuclei. So this is from a cartoon character. The patient has the eyes, but, the cornea are missing. And so we call, she was known as Orphan Annie. And so you see that in these nuclei, the nucleoplasm is pushed to the periphery of the nucleus, and the nucleus looks like the eyes of Orphan Annie. And many of the nuclei show these linear grooves, as you see at the bottom of the picture over here where my pointer is. So, these overlapping nuclei, Orphan Annie nuclei, and linear grooves, you typically associate with papillary thyroid carcinoma. So, this is a tumor of a salivary gland. And so I'll leave it at that. We'll just move to the differential diagnosis. My differential diagnosis was cellular PA, myepithelioma, polymorphous adenocarcinoma, cribriform adenocarcinoma of minor salivary glands. This is if you look at the tumor over here, this is by no way a metastatic tumor. So, even looking at the histology at the lowest magnification, metastatic tumors have, a seeding effect. They don't present as one big circumscribed mass like this. But if you ever have any doubts just based on, this kind of a histology with overlapping nuclei, often nuclei, linear grooves, that this could be a metastatic papillary thyroid carcinoma, chances are very unlikely. You could do TTF1 or thyroglobulin, and that would obviously be negative. So this is a salivary gland tumor. And so here's the differential diagnosis. And so you can see GFAP is negative, P40 is negative. So that immediately rules out a cellular pleomorphic adenoma and a myoepithelioma. And you can see P63 at lower power, it's positive. And so we are left with just these two, polymorphous adenocarcinoma and cribriform adenocarcinoma of minor salivary glands. And you can see S100 is also positive. So here is a table with the findings. And so everything points to these two, polymorphous adenocarcinoma and cribriform adenocarcinoma of minor salivary gland origin. So, polymorphous adenocarcinomas have this Indian filing. It's, goes after the Native Americans, or what we called previously as Red Indians. We don't use that term anymore. We just say Native Americans. So they move with one person behind the other. And so if you look at peripheries of polymorphous adenocarcinomas, you can see that streaking of cells, what we call as Indian filing. And so, they lack polymorphous features. Instead, this tumor had cohesive sheets of cells, plenty of cytoplasm, and papillary thyroid carcinoma-like features. That's overlapping of nuclei, linear nuclear grooves, curved and intended nuclear contours, and the orphan Annie nuclei. So this is what we call as a cribriform adenocarcinoma of minor salivary gland origin. It's an adenocarcinoma with nuclear features reminiscent of papillary thyroid carcinoma, and high percentage of cases present with nodal metastasis. Seems to be slightly more common in females, mean age of 56.8. I believe this patient was 57 years old. So most common location is base of the tongue. This case was in the soft palate, I believe. So it happens very rarely in major glands. So it presents as an unencapsulated tumor. Differential diagnosis is going to be polymorphous adenocarcinoma. And just because of the histology, you have to rule out papillary thyroid carcinoma. And in papillary thyroid carcinoma, these stains would be positive, while in our tumor, these stains would be negative. So resection with free margins, since cervical lymph nodes are involved in 65% of the cases, neck dissection should always be recommended as a part of initial treatment protocol when you make this diagnosis. However, the prognosis is favorable and is not affected by presence of metastasis. This tumor has a very low Ki67 index, only 5% or less of cells are positive to Ki67. So it's not an aggressive tumor by any means. And even though this does have a name, cribriform adenocarcinoma of minor salivary glands, the latest WHO classification tends to categorize it as a variant of polymorphous adenocarcinoma, and they are at present hesitant to give it a unique status. I guess things may change when the next WHO classification comes in, but just be aware of this because it does have findings that are somewhat unique from papillary adenocarcinoma low grade, and that is the nuclear features, the glomeruloid features, and 65% of cases presenting with nodal metastasis, although that doesn't seem to affect the prognosis. Once again, I don't know how much time I spent with you. It's 10:19 in the morning. And I want to thank you for paying attention. And I want to thank Dr. Raj immensely. He's a very good friend of mine and a great buddy of mine, known him for many, many years. And I want to thank the higher administration of SRM And I want to thank you all for allowing me to share these interesting cases with you. Here's my contact info. If you have any questions, I otherwise turn it over to either Dr. Dinesh Kumar or to Dr. Raj. Thank you. If you have any questions, I would be happy to take them.
Yeah, Dr. Rawal, on behalf of the Department of Oral Pathology, SRM Dental College, Chennai, we extend our heartfelt thanks for such a mind-boggling lecture. We are privileged to have had a chance to listen to such a enriching and refreshing speech, sir. We are being showered with huge positive feedback from faculty and student participants from all over India. We are very happy to have had such a wonderful session of yours. Now we'll move on to the question and answer session.
Sure. How are we doing it?
Sir, we would share the question answer in a PowerPoint so that you will also be able to see it, and Dr. Ramya will read it out for you so that it's easy for everybody to see for it.
Okay.
Hope it's visible, sir. Dr. Rawal?
Participants, kindly hold on. Again, there is a technical problem, so we will join you shortly. Just hold on for a minute.
Yes, we are back again. I got disconnected.
Yes, sir. Thank you. Thank you.
Can you? Of course.
Yeah.
Okay, I see the question. In the very first case discussed, I need to move this out of the way. Okay. Clinical multiple whitish yellow plaques and patches and histology also had superficial neutrophilic abscesses. Do we first rule out immunocompromised condition like HIV-associated candidiasis? That should be fairly easy, except that in candidiasis, you're going to see pseudomembranes on the surface. Since they are pseudomembranes, you can easily rub them off, while in this condition, the yellowish areas were submucosal, and clinically you cannot rub them off. So, just immediately, just from this one clinical finding, you know that you're not looking at candida. And of course, in histology, when you have candida in the superficial keratin layers, you do tend to have neutrophilic exocytosis, but they do not form these packets of abscesses. So one is easy to rule out just based on whether you can scrape it or not. And second, if you have failed to do that and all you see is a slide, you can stain with PAS and you may or may not find candida. But these are little pustules, you don't see a more open kind of an arrangement of neutrophils as you would in candida. So this is more confined. It's a really confined abscess. Plus, it's mixed with
We are experiencing a mild glitch over there. Kindly stay put. We will get back.
Yeah,
We are
I'm back.
waiting for Dr. Rawal to connect.
Yes, here I am. Did you hear my response to the first question?
Thanks, Pratibha ma'am, for that elaborate and very elaborate question. I think that would be really useful postgraduate level to get
Yes.
things clarified very clearly. Thank you, ma'am, for sharing your question.
Mm-hmm. You'll have to move to the next question. Okay. How to differentiate cobblestone appearance in ulcerative colitis? Oh, there's no difference. There's absolutely no difference. So clinically, a cobblestone appearance is a cobblestone appearance. So it's not going to tell you the cobblestoning is not going to be different in one GI inflammatory condition from the other. So they're going to be similar. The only thing that's going to allow you to differentiate is all the other findings, systemic findings and the histology, the GI findings, gastroscopy. So I would not rely on any difference in cobblestoning. It's the same thing in both conditions. They do not differ. Does it answer that question?
Yes, sir. Thank you, sir. Thank you, Dr. Karthik, for the question. Thank you. We are moving on to the next question, sir.
How do we standardize the preparation of a stain like Congo Red? Is there a good protocol to prepare a stock and use it when needed to prepare it freshly when staining needs to be done? Well, so this is a technical question, and the answer to that is to know whether your stain is good or not is tested based on a positive control. So, every time, at least over here, when we request the lab for stains, they always have in their repository large collections of tissue that are known to have, in this case, amyloid. So what I would recommend is if you have resources in a hospital setting, and if you can request them, do you have a case of, say, lung amyloid? Or do you have a case of liver amyloid? Those are common things. And if they can part with a block of tissue and give it to you, you can keep that in your lab as a positive control. And so when you have a suspected case in your practice, make a cut of your positive control and stain it simultaneously with your specimen. So then you will know whether your stain is working or not. I hope that answers your question.
Yes, sir. Sure, sir. Thank you so much. Thank you, Dr. Soumya Anandan, for that question. We're moving on to the next question, sir.
What would be the treatment for ligneous gingivitis? So typically they have used applications of warfarin and careful denudation of these plaques. But I would refer you to many of the publications on oral ligneous gingivitis and ligneous periodontitis for more elaborate description. There have been different modes and methods in how several groups of authors have treated these cases. But typically it is careful denudation and application of warfarin. And please look at, you can look PubMed and pull up some of these articles and see how individual groups have managed their different cases. But typically it is going to be careful surgical denudation with application of warfarin. Does that answer the
Thank you so
question?
much, sir. That
Yeah,
was,
of course.
yeah, yes, sir. Perfect, sir. Thank you so much. Thank you, Dr. Sonali Shah, for that question. For the next question.
How to differentiate carbon? Oh, I thought
Sorry,
we
it's
already. Is that okay?
sorry. I moved
What
on to
is
the
the
next.
what is the incidence rate of Rosai-Dorfman in head and neck? Well, I don't know about that. There have been several reports. The head and neck is a broad area. So, you know, most cases of Rosai-Dorfman do tend to present in cervical lymph nodes. So, you know, 75% cases of Rosai-Dorfman are in the head and neck, if that answers your questions. But the reports of extranodal disease are few and far in between. And so it does tend to affect the cervical nodes. It's reminiscent like Hodgkin's lymphoma or lymphoma, if you like. But so far as we people are concerned, we should be aware of the extranodal presentation in the jawbones, in the oral mucosa, in the nose, in the paranasal sinuses. And so, you know, I would highly recommend that you know, look up that paper that I referred you to. It's a multi-center study and probably the largest collection of extranodal head and neck cases of Rosai-Dorfman disease. Okay.
Thank you, sir. Thank you for the reference citation. Thank you, Dr. Samira. There's a next question.
Oh, the cause, we don't know. It's, let's put it as idiopathic. It's, you know, there's no genetic mutation. There's no genetic predisposition. It's not familial. It's not transmitted. It happens spontaneously. So we don't know the cause of miliary osteosis. I hope that answers your question.
Yeah, yes, sir. Perfect, sir. Thank you. Thank you, Dr. Ashwati. So the next question.
As dripping wax pattern is pathognomonic, how soon is it seen? Right at the onset or later along the course of the disease? Well, you know, the patients typically present with limb deformity, you know, fusion of epiphyseal plates. And so you can see these patients having joint stiffness and a shortened limb on one side. And so that should, you know, how shall I say, excite a person towards that diagnosis. And so if radiographs are taken, you are going to see that hyperostosis of the epiphysis and the diaphysis. So a dripping candle wax, of course, is going to be a more delayed feature. It's not going to be an early feature because the hyperostosis has to spill from the inside of the bone to the outside. So it's not an early feature by any means. The dripping candle wax is going to be a more delayed finding, if that answers your question.
Yes, sir. Thank you so much. So that picture which was projected for the dripping wax pattern is just staying in my eyes, and I think everybody would have felt the same. We would never forget that appearance again. Thank
Yes.
you so much.
Yes.
Yeah. Moving on to the next question, sir.
What's the value of preliminary cytosmears for gingival pathologies? Oh, so, you know, it's a very broad question. Cytosmears are not very popular over here. You know, we tend to use cytosmears in very rare instances. You know, if you want to see Zang cells, say Zang cells in viral infections, so viral cytopathia, or if you want to see Zang cells in pemphigus. Otherwise, cytosmears are not very popular over here. They were using cytosmears for what's known as a brush biopsy to evaluate for dysplastic cells. But you can use cytosmears for, you know, diagnosing candida when you see pseudomembranes. And so you can, you know, take a smear of the mycelia and put a potassium hydroxide, you know, liquid on a slide and look at it under the microscope to see the hyphae. But the use of cytosmears for diagnostic purposes is very limited. And so, using cytosmears is not something that is done on a routine basis over here.
Okay, thank you, sir. But here we have the Dental Council recommending strongly on regular cytology, conduct of regular cytology. But your answer has really enlightened us, sir. I'm moving on to the next question.
So can I ask you?
Yes, sir. Yes, sir. Dear all, I think there's again a small lag, technical glitch. Please hold on. We are waiting for Dr. Rawal to respond.
Again.
Yeah, yes,
So
sir.
it keeps dropping, the connection keeps dropping, but at least we are able to connect again.
Yeah, yes, sir.
Okay, so I was just asking you, like the Dental Council asks for cytosmears for what? Diagnosing dysplasias?
No, sir. It just encourages us to have a routine backup of cytology for parallel biopsy cases that we do. It's a part of regular curriculum for oral pathology specialty.
Huh. Okay, well, I don't know the value behind that, but that's how, if they want you to do it, I guess you got to do it. Okay, so next question, is there any relationship between lichen planus and lichen amyloidosis? I don't see any relationship. It's just that, when you have chronic inflammation, as in lichen planus, the possibility with basal cell destruction, the possibility that in rare cases, it could result in deposition of amyloid. That's the A-keratin amyloid. It's theoretically possible. The only thing is lichen planus is, especially erosive lichen planus, where you see heavy inflammation, is a fairly acute and progressive and severe inflammatory condition. So, and cases of lichen amyloidosis are so rare. And so, I would be hard pressed to jump into that conclusion that there is a relationship between lichen planus and lichen amyloidosis. Just because of the word lichen, I wouldn't draw that conclusion. That is just another name, lichen amyloidosis is just another name for this condition. Because you see inflammation and you see deposition of amyloid, some people called it as lichen amyloidosis. So I would not make that connection right there just because of the name. It's just another name. There are so many such pseudonyms in oral pathology. Pyogenic granuloma, there's no pus and there are no granulomas. So we still call it as pyogenic granuloma. So don't draw that immediate conclusion just because of names that sound alike.
That made it really clear, sir.
Yep.
Thank you.
Mm-hmm.
Moving on to the next question.
How to differentiate morning stiffness of osteoarthritis and Millariostosis. Okay, so this is very easy. So does your little baby suffer from morning stiffness, or does your grandmother suffer from morning stiffness? So who suffers from osteoarthritis? Does the little baby or the grandma? The answer is pretty obvious, isn't it? Osteoarthritis is a degenerating joint disease seen in older people because of obesity or age. So you tend to see this in older people. So morning stiffness in older people is not Millariostosis. Okay, it's osteoarthritis. Millariostosis is a condition typically seen when the epiphyseal plates are still not fused. So in growing bones in children. So most cases are under 20 years of age. I hope that answers your question. Very straightforward answer, right?
Yeah. Yes, sir. Very straightforward. Thank you, sir.
Yeah.
Thank you, sir. Yeah. Yes, sir.
What is, I thought we covered this,
No,
right?
that was already done. Yes, sir.
Oh, yeah.
So,
Okay.
it's time to again, thank you again, sir. Many thanks from the Department of Oral Pathology on behalf of our HOD, sir, Dr. K. Rajkumar, and the entire energetic team behind which made the webinar successful. I extend my heartfelt thanks to you, sir, for having shared your very rare presentations, many of which we've been hearing for the first time. And we have been getting excellent feedback for the session, sir, which we would be sharing with you. And this is a very small token of appreciation from our end. Thank you so much, sir. And I would like to thank all the senior faculty members who have really given their unstinted support to us by spreading the word among the peers and the students. And we have had really good numbers to watch this presentation. I hope all of you benefited with this. As an ending note, please share your email IDs, and also please do not forget to answer the feedback which would pop up immediately as you leave the webinar. So once you leave the webinar, there will be a pop-up which asks for a feedback survey, which is very important for you to get your certificate. So please spend a few minutes to answer that, and we would be sending the certificates by mail to you within 1 or 2 days. Thank you so much. That was a very lovely participation from all of you. Thank you so much.
Well, thank you very much again.
Yes, sir. Thank you so much.
Thank you, Dr. Yeshwant. Yeshwant, this is Dr.
Thanks,
Rajkumar.
Raj.
Thanks a lot, Yeshwant. Yeah, it was excellent.
Yes.
Thanks a lot for having taken so much of trouble in doing this presentation. Thanks a lot, Yeshwant.
Of course.
Thanks a lot.
Yep, my pleasure, Raj. You take care, okay?
Okay, right.
And
Thanks a lot.
Say hi to KK, DJ,
Yes,
Krishna Raj, Ravi, and everybody, okay?
Yeah, definitely I'll do that, Yeshwant. Thanks a lot. Thanks a lot. Thank you.
Bye.
Bye. Thank you.
Bye.
Thank you, participants, for all your patience being here. We would close this session now. All of you would receive the link of the entire presentation with Rawal sir's permission. So the entire recording would be shared to all of you for later viewing. Thank you very much once again. Signing off from SRM Dental College, Ramapuram, Department of Oral Pathology. Thank you all.